If you were just diagnosed with low-risk prostate cancer, you've probably been told two completely opposite things. Treat it immediately, or you don't need treatment at all. Today, I'm going to show you what actually happens to men who choose active surveillance, using the best long-term data that we have. As an outline, we'll talk about the definition of low-risk prostate cancer and active surveillance, the workup, some of the historical changes in the guidelines, the major trials that have gotten us here today, predicting who will die of prostate cancer, and when to initiate treatment. The major theme that you will see throughout this presentation is predicting cause of death. And just some memorable quotes to keep in mind. Number 1, don't order a test unless it's going to change your management. Number 2, you can only harm men with low-risk prostate cancer by treating them. And 3, most men die with prostate cancer rather than of prostate cancer. So what is low-risk prostate cancer? It's a combination of these 4 factors. Number 1, it's Gleason grade group 1. This is also called Gleason 3+3=6 disease. That's the older definition of it. Having a PSA less than 10 nanograms per milliliter. T1C disease. This means that it was PSA or screening detected and a physician is unable to palpate it on a rectal exam. They can't feel any kind of cancer. And less than 50% of cores involved on a standard template biopsy. And this does not include the region of interest. And that means that you can't be selectively trying to biopsy the thing that looks abnormal on an MRI and including it in the biopsy. And you can watch our staging video for more information about this. So this is one of our favorite figures. It comes up in many of our presentations. And here I'm showing you the risk groups in rows. And you can see very low and low risk prostate cancer are these 2 top columns. And active surveillance applies to men in this area of the box. What if we were to flip these columns and now the columns are rows and rows are columns, and now we have low and intermediate risk disease here, and we have possible treatments on the very bottom of the page? Well, active surveillance refers to these patients here. And here's a quick summary of active surveillance. It's a PSA every 6 months, a digital rectal exam with a biopsy no more than every year, and an MRI more than every year, and no metastatic staging. We'll get into those details momentarily. The workup. The main thing that you want to do for low-risk prostate cancer is consider an MRI. And this is right around the time of the biopsy and maybe used to guide the biopsy in the modern era. In general, for low-risk prostate cancer, you do not need any other scans. What are some of the changes in guidelines? Over the past 15 years, the major changes have been an emphasis on active surveillance and the integration of tools to predict cause of death. So I'm going to take you back to 2013. Here are the national guidelines in the US. And these guidelines recommended that for men with very low and low risk prostate cancer, if their expected survival was less than 20 years, active surveillance had a recommendation, but it had something called a category 2B recommendation. It was basically preferred, but we didn't have super strong evidence at the time. We didn't have major randomized trials, at least at this time, that suggested that it was the ideal treatment. The other note you'll see here is that even for men with low risk prostate cancer with a expected survival of more than 10 years, radiation therapy was actually a treatment option. It was along the same lines as active surveillance. So what happened in the past 13 years? Here is low risk prostate cancer, men with expected survival more than 10 years. Active surveillance is preferred for most patients. And even if their survival is less than 10 years, their recommendation is observation. What about favorable intermediate risk? Well, active surveillance is presented here as well for men with an expected survival of more than 10 years. An observation you can see here for those with an expected survival of less than 10 years. What is active surveillance? The national guidelines define active surveillance as actively monitoring the course of disease with the expectation to intervene with curative intent if the cancer progresses. It involves PSA monitoring and longitudinal and serial pathologic assessments via prostate biopsy, often guided by MRI. There are 3 phases of active surveillance. 1, candidacy. 2, confirmation of candidacy. And 3, active surveillance. So basically they're saying, make sure that this person qualifies, and then do it. The key principles. Number 1 is checking a PSA no more than every 6 months unless clinically indicated. And it is rare that you need a PSA more than every 6 months. And there are some men we see in our clinic who want a PSA every 2 or 3 months. I can just tell you that it's really not necessary. The PSA will fluctuate akin to checking your weight on the bathroom scale every day. There will be changes from day to day, but that does not mean that your weight and your health overall is necessarily changing. Number 2 is a digital rectal exam, or DRE, no more than every 12 months. 3 is a repeat prostate biopsy, not more than every 12 months. 4 is considering a repeat prostate MRI, no more than every 12 months. 5 is for patients with a suspicious lesion on the MRI, an MRI targeted biopsy. Specifically, that is done to try to improve the detection of higher grade cancers. So that is grade group 2 and above. Patients should transition from active surveillance to observation when their life expectancy is less than 10 years. And finally, metastatic staging evaluation, specifically with PSMA PET, bone scan, CT, or whole body MRI, should not be performed unless the patient develops unfavorable intermediate risk disease or higher, or unless there are concerning symptoms. But I can tell you that in practice, this is almost never happens. I mean, less than a percent of patients will be in this bottom category. What are the differences between active surveillance and observation? We talk about them like they're the same thing, but there are actually some important differentiators. Observation involves monitoring with a history and physical no more than every 12 months without surveillance biopsies, imaging, or PSA monitoring until symptoms develop or are thought to be imminent. So in other words, observation is generally used for patients in much poorer health and who may unfortunately pass away within the coming years because of their other medical conditions. Why are we doing active surveillance? One of the principal advantages is that approximately 50% of those eligible for active surveillance may safely avoid treatment for 10 years. Now, this does vary by baseline risk, and we'll show you some of the data momentarily. By avoiding treatment, patients will avoid or delay possible side effects of treatment, and quality of life will be less affected while on active surveillance. The risk of unnecessary treatment of small indolent cancers will be reduced. Why is this the case? And we've actually known this since the 80s and 90s. Remember that the 90s were the era when PSA screening was introduced. And we saw that with data going back into the 80s and 90s, that most men of prostate cancer will die of a competing cause like a heart attack. So this is a paper that was published in JAMA back in 2005. And here the authors break down the age at diagnosis going from the 50s through the 70s and the type of cancer that they had based on the Gleason score. And for us, the most important variables or the rows that are presented here are Gleason score 6 and 7. And you can see that the majority of patients with Gleason 6 disease were dying of something else. Now, I want to tell you that this is a relatively old paper, probably does not apply to patients seen today because many of them are seen with PSA screening and MRIs, and we have many more patients who are dying of competing causes, not of prostate cancer. So these ratios are going to be different in the modern era. And just some of our research, we've shown that most men with prostate cancer will die of a competing cause like a heart attack. So here are many other cancers that are diagnosed in the US, and from the time of diagnosis and until follow-up, so this is 10 plus years of follow-up on the x-axis, you can see that heart disease actually starts to overtake prostate cancer as a cause of death among men who are diagnosed with prostate cancer. The number of men dying of cardiovascular disease versus prostate cancer is also increasing over the decades. And cardiovascular disease includes things like a heart attack, stroke, aneurysm, high blood pressure, etc. And the reason in part we're seeing this is because of PSA screening and the detection of much lower risk prostate cancer. So in other words, we are flooding the system with cancers that will probably never progress. And one of the things that I tell my patients is that the risk of a man having prostate cancer is basically his age followed by the percent symbol. So if you're 65, the chance of you having prostate cancer is 65%, thereabout. And if we were just to do random biopsies of all the men that we saw along the street, you would see that there would just be a higher chance of finding prostate cancer among anyone that's walking along the street. What are some key active surveillance trials? There are 3 main trials, and I want to focus mostly on the last one called PROTECT, but there was a trial called SPCG4, PIVOT, and PROTECT. The first 2 trials were conducted in a slightly older era, and they also compared something called watchful waiting, and they compared it to either radical prostatectomy or radiation therapy. Now, watchful waiting is also a slightly different definition than active surveillance, but these 2 trials in general showed that watchful waiting or active surveillance was a reasonable treatment approach for low and favorable intermediate risk disease. PROTECT is a trial that is much more applicable to the current era than these 2 other trials, even though PROTECT is a little bit outdated today as well. And you've probably seen our other videos. This is like one of the holy grails of trials in GU oncology. It took men with mostly low and favorable intermediate risk prostate cancer, and it randomized them to active monitoring, radical prostatectomy, or radiation therapy. One of the key things that the trial showed was that the metastasis-free survival, so the chance of having metastasis, was almost the same between surgery and it was the same between surgery and radiation. It was only slightly higher in the active monitoring arm. Now, numerically, you can see that at 15 years, that delta is about 5% absolute difference. And so it is still very low. And one of the thoughts that sometimes men have is, well, I don't want to be one of these men who has progression. And sometimes men hear progression and they think death, but the data just does not support that conclusion. So PROTECT showed the same prostate cancer specific survival. So that is the chance of you dying of prostate cancer, no matter which of the 3 arms you were in, was the same for 17 years after enrollment into the study. Another question that men often ask is, well, what about my quality of life? Won't I feel more anxiety, depression, etc. if I don't have the treatment? Wouldn't it just be better to receive surgery or radiation? And the short answer is no. From this trial, the data on physical health scores, mental health scores, anxiety, and depression were collected, and they were similar among the 3 arms. One small caveat for this trial, something called Cribriform prostate cancer. We do have a separate video on this, and I encourage you to watch it. And this trial, about 42% of patients had grade group 2 or above prostate cancer. And here I'm showing you the breakdown. And this is a secondary analysis of the trial looking at this thing called cribriform prostate cancer. It just looks a little different underneath a microscope. Cribriform was the only major risk factor of metastasis in their multivariate model. For patients who had cribriform prostate cancer, specifically with Gleason scores of 4 + 3 = 7 or 3 + 4 = 7, you can see that the cumulative incidence of metastasis was higher. And so based on the secondary analysis, it is suggested that this type of prostate cancer is not safe to monitor. The rate of metastasis, if it is not monitored, is just higher on any one of the treatment arms. Now, one of the interesting themes that was seen in this trial, and this is retrospective data, but was that radiation therapy plus short-term hormone therapy was actually more effective than surgery at preventing metastases. And I encourage you to watch our video on metastasis and hormone therapy and why hormone therapy is meant to treat metastases. With all of that out of the way, the next theme we want to focus on is how do we predict life expectancy? And unfortunately, this is sort of like a crystal ball. And so the national guidelines now give us a few tools to try to predict life expectancy. The first tool is very basic. It is the Social Security tables, and it actually links to the US government website where the age is listed of someone who's 60 years old, and it will tell you what is the life expectancy of someone who's 60. It's about 22 years. What about someone who's 80? Well, it's only about 8 years. And so patients can use this potentially as a guide to help them decide if they want to get treatment or not. In addition to this, other nomograms have been introduced. So for example, Memorial Sloan Kettering Cancer Center, this is a famous cancer center in New York City, has introduced a male life expectancy calculator. And this is more complex than the Social Security tables. And you can go to the MSK website and it will ask you many questions about your health history, including chest pain, congestive heart failure, cigarettes smoked, your lipid ratios, etc. And it will tell you, based on the values that you put in, what is the expected survival. Also, from some of my videos, you know that one of my focuses is trying to predict mortality and recommend treatments like exercise therapy to try to have a long and healthy life. And a lot of my research focuses on this. And there's also just a whole slew of research looking at cardiovascular health and predictors of a long and healthy life, at least in terms of physical fitness. And so here are just some of the tests that are used. And you can also look at lipid panels to try to predict mortality. There are numerous studies that are looking into this. And so I often will try to look at a patient's lipid ratios, things like triglyceride levels, the total cholesterol versus the HDL ratio, and the triglycerides versus the HDL ratio. How do we decide on initiating treatment? So let's say a patient is on active surveillance and we're thinking, well, has the PSA gone up enough? Maybe we want to start treatment. And here, let's start with what the guidelines say first. First, for low-risk disease, grade reclassification on repeat biopsy to grade group 2 or higher is the most common factor to transition off active surveillance to treatment. PSA alone, or growth in size of the tumor on MRI, assuming that it is organ confined, should not be used alone to stop active surveillance without histologic confirmation of progression. So, in other words, you may often see that your PSA is going to fluctuate. It's going to go up and down, just like your weight when you check it on a scale every morning. And your PSA can go up and down for various reasons. It can be affected by medications that you're taking. It can be affected by sexual activity. It can be affected by inflammation and irritation in the prostate and the urethra and the bladder. So I personally don't put a lot of stock into PSA to recommend treatment initiation. When there is grade reclassification, patients can be reclassified to have favorable intermediate risk disease. And so there can be an increase in the percent of pattern 4. There can be an increase in the tumor volume on biopsy or imaging, or a rise in PSA density. And so these are some of the more common factors to transition off of active surveillance to treatment. The last thing that the guidelines mention is that patient anxiety is commonly cited as a reason to transition off active surveillance. However, studies indicate that anxiety is closely linked with provider education on the safety of active surveillance. Thus, if a patient is an excellent candidate for active surveillance and has anxiety, the provider should provide appropriate education on the safety of active surveillance. Another study, and this is from the UCSF group, to try to tailor active surveillance versus treatment for low-risk prostate cancer, is this nomogram from Canary Pass. And so you can go online and you can put in various variables in the model, and the model will give you a prediction of the risk of Gleason upgrading and perhaps of you needing treatment and even dying of prostate cancer. So this website is excellent, and I commend the authors on making this excellent model. I'm showing you just some of the features and some of the screens that are available online if you choose to use this website. So, in conclusion, I want to remind you that active surveillance isn't about avoiding treatment. It's about avoiding treatment that you will never need.